Topic for presentation is association between retinal hard exudates and lipid profile in diabetic retinopathy patients, a cross-sectional study. Coming to introduction, diabetic retinopathy is one of the most common microvascular complications of diabetes mellitus. While diabetic retinopathy can affect the entire retina, the most frequent cause of vision loss in this disease is the involvement of macula. This condition is known as diabetic macular edema. Hard exudates are a classical clinical sign of chronic severe vasogenic retinal edema and are particularly prominent in patients with diabetic macular edema. Dyslipidemia plays an important role in the pathogenesis of these hard exudates. Elevated serum cholesterol and LDL levels may exacerbate vascular leakage and deposition of lipids in the retina. Coming to aims and objectives, aim to evaluate the association between retinal hard exudates and lipid profile parameters in diabetic retinopathy patients. Study design, it is a hospital-based cross-sectional study. Duration was from March 2024 to May 2025. Diabetic retinopathy grading using ETDRS classification. Total 100 diabetic retinopathy patients were included, divided into two groups. Group A consists of 50 DR patients with a CSME and Group B consists of 50 DR patients without CSME. Inclusion criteria included diabetic retinopathy patients whose age above more than 40 years and duration of diabetes more than 3 years. Exclusion criteria excluded type 1 diabetes mellitus patients, patients with AC media, and patients with non-diabetic maculopathy. Patients undergone prior laser or intravitreal therapy, under uncontrolled hypertension, and patients who are on lipid lowering drugs were excluded. Method of data collection, all study subjects underwent comprehensive ophthalmic evaluation. Hard exudates graded using ETDRS standard photographs, and lipid profile and HbA1c were measured. The best corrected visual acuity of worst eye was used for analysis. Instruments of study: stereoscopic slit lamp biomicroscopy with plus 90D Vogt lens, indirect ophthalmoscopy with plus 20D Vogt lens, and SDOCT. Coming to results, the data was analyzed using ANOVA statistical test. Majority of aged 50 to 70 years. No significant association with age and gender. Strong association with poor vision and poor HbA1c. Association with hard exudates and clinically significant macular edema. Severe hard exudates are predominantly in CSME group. Total cholesterol and hard exudate severity. Increased severity of hard exudates was associated with progressive rise in mean total cholesterol levels. HDL and hard exudate severity. Increasing severity of hard exudates was associated with progressive declining mean HDL cholesterol levels. LDL and hard exudate severity. A significant positive correlation was observed between hard exudate severity and mean LDL cholesterol level. VLDL and hard exudate severity. Increased severity of hard exudates was associated with progressive rise in VLDL levels. Triglyceride and hard exudate severity. Increased severity of hard exudates was associated with progressively higher serum triglyceride level. Coming to discussion, this study highlights a significant association between dyslipidemia and severity of retinal hard exudates in patients with diabetic retinopathy. Increased severity of hard exudates was associated with elevated levels of total cholesterol, LDL cholesterol, VLDL, and triglyceride, while lower HDL were linked to greater hard exudate severity. Landmark studies including ETDRS and Westner's DR study, which also reported a strong correlation between dyslipidemia and retinal hard exudates. Limitations of study. It is cross-sectional study. It cannot establish causality. It is single center study. It limits external validity. Moderate sample size may reduce statistical power, and findings may not be generalizable to the wider diabetic population. Coming to conclusion, dyslipidemia and poor glycemic control show a strong association with increasing severity of retinal hard exudates in diabetic retinopathy. Higher grades of hard exudates correlate with increasing total cholesterol, increasing LDL, and increasing VLDL, and increase in triglyceride, and decrease with HDL. Severe hard exudates strongly associated with clinically significant macular edema and greater vision loss. Integrated management of dyslipidemia and glycemic control is essential to reduce the risk of CSME and protect visual outcomes. Early identification and modification of risk factors can help prevent progression of diabetic macular edema. These are my references.
Coexistent hypertension, uremia, anemia, all also will affect to an extent hard exudate distribution. We all know that. In a uremic case, we consider there will be more hard exudates. So that is not clean. Your data is not clean for that. It just says LDL is high. Whether that person also has CKD, you never looked at. So then that compounding effect of two different disorders causing more hard exudates is important. We'll have to show that. Only then you can show one-to-one association. Second point, hard exudate, how much of hard exudate you don't have a measure. You don't have a tool to say if it is just one speck of hard exudate or it's just a big patch of hard exudate right on the fovea, you don't have a measure. Then that becomes like one size fits all. That should not be there. You should try to put hard exudates as a mapping. You should map hard exudates and say like between them one disc diameter of hard exudates or two disc diameters of hard exudates. Like that, you'll have to create a measure for the hard exudates and then say in these patients where you had high uh, lipid levels, they were high. Only then that causality can come. Okay.
I agree with sir that you haven't defined your measure, that what was the criteria on SDOCT to say them that's questionable or mild, moderate, severe. So that you haven't defined in your study.